Good morning. My name is Khushi Khandelwal from Bharati Vidyapeeth deemed to be University Pune. I would like to thank Salsi to provide me this great opportunity to present. Today, topic for my presentation is saliva in oral cancer diagnosis. Cancer sounds terrifying, right? It is as it can be fatal. The reason for deaths due to cancer is usually due to its late diagnosis when complete cure is not possible. Today, I'll cover my topic under following headings. Introduction. WHO classification of 2017 defined oral cancer as tumors in the buccal mucosa, the anterior two-thirds of the tongue, the lip, palate, vestibule, alveolus, floor of the mouth, and gingiva. Oral cancer is a malignant head and neck disease which accounts for 2 to 5% of cancer types and around 30% of head and neck diseases. In India, 20 per thousand population are affected by oral cancer and over 5 people die every hour every day because of it. According to Globocan 2018, there were 119,992 new cases with 72,616 deaths due to oral cancer in India. Oral cancer is one of the most frequent types of cancer, being responsible for 9% of death worldwide. Head and neck squamous cell carcinoma being the most frequent type of cancer which affects cervical and oral lesions. It has a very low 5-year survival rate due to late diagnosis, high degree invasiveness, and development of therapeutic resistance. In spite of advancement in reconstruction surgery and adjuvant therapy in recent decades, oral cancer still remains the public social healthy problem because of its high incidence and morbidity. These high morbidity rate can be attributed to a number of factors, which includes non-responsiveness to chemo and radiation therapy, late presentation of lesions, and lack of biological markers for its early detection. Now, what causes oral cancer? There are various etiologic factors which can lead to the development of oral cancer. These include tobacco, alcohol, HPV infection, brittle quid chewing, poor diet and nutrition, poor oral hygiene, oral microbiome alteration, and genetic susceptibility. Out of these, tobacco chewing is the most potent high risk factor which can lead to the development of oral cancer. Due to its high consumption, the prevalence of oral cancer in India is high. Saliva. Saliva is mainly composed of fluid produced by major and minor salivary glands. Major salivary glands include parotid, submandibular, and sublingual gland. Saliva carries molecules and cells originated from aerodigestive tract as well as nucleic acids and proteins that are transported from circulatory system into the salivary gland. This allows for the application of saliva in the diagnosis of not only salivary gland disorders but also oral and systemic conditions. Now, the question arises why saliva should be used instead of blood in the early diagnosis of oral cancer. The first is that saliva maintains continuous contact with these cancer regions. Saliva sample collection is the easy, non invasive approach and also comfortable for the patient. It also contains salivary biomarkers, thus making it appropriate for the use in the early diagnosis. Now, what is a biomarker? Biomarker refers to a measurable and quantifiable biological parameter that can serve as an indicator for health and physiology related assessments such as pathogenic process, environmental exposure, disease diagnosis, and prognosis or pharmacological response to a therapeutic intervention. Salivary biomarkers plays a non-invasive role in the diagnosis and surveillance of oral cancer lesions, making it the most sensitive and specific screening method in diagnosing, staging, and follow-up. It can be used for screening large population and can serve as an effective tool in early identification. Salivary biomarkers are classified into genomics, which includes DNA and RNA, proteomics, which includes proteins, peptides, and antibodies, and metabolomics, which includes lipids, carbohydrates, enzymes, and metabolites. Materials and methods. First is the saliva sample collection. Unstimulated saliva sample are obtained from all the subjects in the morning. These subjects are instructed not to eat, brush, or rinse their mouth at least 2 hours before the collection of sample. The subjects are then instructed to swallow and make chewing motions for 30 seconds and are told to tilt head forward and expectorate 5 ml of the saliva into the sterile container. The individuals included in the studies should be histopathologically confirmed cases of oral squamous cell carcinoma aged 18 years or above and consented to participate. The control group include healthy individuals with no tobacco habit and other comorbidities. Estimation of biomarkers. The samples were transported on ice to the laboratory for the immediate processing. The first biomarker is matrix metalloproteinase 9. Matrix metalloproteinases, MMPs, are secreted by both normal as well as tumoral cells and have role in degradation and remodeling of extracellular matrix. They can lead to fragmentation of FAS receptors, reduction of the natural killer cells, and prevent apoptosis. They have dual role in angiogenesis, increase bioavailability of VEGFR, disintegrate several proteins, chemokines, cytokines, and alter their receptors to regulate cell growth and inflammation. These are classified as gelatinase, collagenase, stromolysin, and membrane type. MMPs function as mediator of alteration of carcinogenesis. They may also have role in the regulation of initial steps of carcinogenesis and invasion. It causes proteolytic disintegration of the basement membrane by directly targeting meshwork of type 4 collagen as well as collagen 5, 7, and 10, fibronectin, and elastin. This is a critical step that facilitates the tumor invasion and its metastasis. The MMPs sustain the bioavailability of growth factors, thus aiding in the proliferation of these cancer cells. MMP secretion is induced by high levels of interleukin 6, linking inflammation and invasiveness, which are the key processes of oral cancer development. They have sensitivity of 100% and also releases cytokines, chemokines, and growth factors. Tissue inhibitors of MMPs are a group of 4 classes of proteins that block MMPs action. In normal tissues, there is balance between these two, regulating the ECM formation and degradation. The next biomarker is chemarin. Chemarin is a novel adipokine secreted by adipose tissues and variety of other tissues. They have shown to exert important regulatory function in various aspects of human physiology or pathophysiology via G protein coupled receptors. Chemarin can increase morphogenesis and proliferation of endothelial cells, induce their migration, activate key angiogenic pathways, and induce angiogenesis in tumor cells. The next biomarker is RNA. Exocytosis is one mechanism for accumulation of ribonucleic acids in saliva. So the careful profiling provides insight into the diagnosis of oral cancer. In oral squamous cell carcinoma, the transcripts of specific mRNAs and microRNAs is altered. Messenger RNAs are a family of molecules that convey information from the DNA to the ribosome. A significant elevation was noted in 7 mRNA transcripts that include DUSP1, H3F3A, IL1B, IL8, OAZ1, SAT, and S100P. MicroRNAs can be potential biomarkers in the diagnosis of oral cancer, and their expression increases to a significant proportion, even several times, as compared to mRNAs. miRNA 21, 27B, which is overexpressed, 136, which is underexpressed, are the microRNAs which are expressed in oral squamous cell carcinoma with specificity of 100%. Next biomarkers are cytokines. The cytokines are chronic inflammatory mediators which has been associated with cancer. They alter the matrix proteins and promote angiogenesis in tumor cell. Pro-inflammatory and anti-inflammatory cytokines are produced and released in the tumor microenvironment by tumor and immune cells. The salivary levels of interleukin 8, 6, TNF-alpha, 1 beta, and interleukin 1 alpha were significantly higher in oral cancer patients. Interleukin 8 is a chemoattractant cytokine which functions in the immune surveillance, inflammation, and angiogenesis. It acts as a potent angiogenic factor in the tumor by modulating tumor cell proliferation and their migration. Interleukin 6, promptly and transiently produced in response to infections and tissue injuries, contributes to host defense through stimulation of acute phase response, hematopoiesis, and immune reaction. These interleukin 6 are released by various cells, including cancer cells. Ki67. Cellular proliferation is a fundamental characteristic of cancer. Ki67 protein is a cellular proliferation and a prognostic marker. It is encoded by Ki67 gene and is expressed in all active stages of cell cycle and absent in the resting phase. This characteristic makes this marker a great tool for monitoring the growth rate of cellular population, both in tumoral as well as potentially malignant lesions. The high levels of Ki67 in oral cancer patients shows the active proliferation, which is characteristic of these type of cancers. The next biomarker is combination of choline, betaine, pipercolinic acid, and I-carnitine. These combinations have the highest sensitivity of 100% and specificity of 0.97. Choline is important as a precursor of acetylcholine, as methyl donor in various metabolic processes and in lipid metabolism. In tumor cells, Choline metabolism is the main method of phosphorylation metabolism. The excessive proliferation of cancer cells require high-level conversion of choline into phosphatidylcholine for membrane synthesis. Betaine functions very closely with choline as a methyl donor and also plays a role in synthesizing of L-carnitine. Pipercolinic acid is a cyclic amino acid which is produced during the degradation of lysine. Its level is increased in oral squamous cell carcinoma due to upregulated lysine metabolism. L-carnitine is an essential factor in fatty acid metabolism, and its most important known metabolic function is the transport of fat into the mitochondria of the muscle cells. The L-carnitine content is slightly lower in oral cancer patients due to downregulated fatty acid metabolism. Next is a combination of N-leucine and N-phenylalanine. This combination has high sensitivity of 0.93 and specificity of 0.92. L-phenylalanine is an essential amino acid and the precursor of tyrosine. The decreased level in oral squamous cell carcinoma saliva appears to be the result of enhanced energy metabolism or upregulation of the appropriate biosynthetic pathways and required cell proliferation in oral cancer tissues. L-leucine is a branched amino acid critical to human life and solely to fat metabolism. Substantial amount of L-leucine are generated by protein breakdown. In oral squamous cell carcinoma, L-leucine content in saliva is decreased as compared to healthy people, probably because the increased metabolic utilization by the TCA cycle in oral cancer cells. The next biomarker is CIFRA-21-1. CIFRA-21-1 is the serum soluble fragment of cytokeratin 19. In oral squamous cell carcinoma, to early detect this tumor, it usually links the squamous cell component to cancer. Cytokeratins are the structural protein forming the subunits of epithelial intermediary filaments. The pool sensitivity and specificity ranges from 0.68 to 0.99 and 0.65 to 0.93 respectively. Since these cytokines have average sensitivity and specificity, they are used as a prognostic markers rather than the diagnostic markers. Advantages of salivary biomarkers. Employing saliva in liquid biopsy for oral squamous cell carcinoma management has many advantages over other specimens. First, it is considered a mirror of the body reflecting any physiological or pathological change on local as well as distant sites in the body. Second, it represents an easier, quicker, and more accessible screening tool. Third, it gives the opportunity to collect larger volumes of samples for examination, to easily repeat analysis, and to monitor it over time. Fourth, it is readily available specimen which can be collected by non-invasive techniques. Disadvantages of salivary biomarkers. In order to translate these biomarkers into clinical practice, standardization of saliva collection as well as a larger and multicentric studies are required. A biopsy test, which is a gold standard, is still mandatory for diagnosing oral cancer. Despite of advantages of salivary biomarkers in the diagnosis of oral cancer, furthermore studies are required to use these biomarkers in the clinical practice. Thus, to conclude, in addition to oral clinical examination, screening by various imaging modalities and biopsy, salivary biomarker assay can be supplemented for early detection and progression of oral potentially malignant diseases and oral squamous cell carcinoma. Developing a non-invasive saliva-based testing kit could be used as a new diagnostic adjunct for a community screening of subjects with oral squamous cell carcinoma and oral potentially malignant diseases. Randomized controlled trial could be done to these salivary biomarkers for screening and diagnosing oral squamous cell carcinoma. Salivary biomarkers, which are highly sensitive and specific, can be used as a diagnostic tool. Biomarkers like MMP9, chemarin, interleukin 8, 6, and microRNA are highly sensitive and can be used in mass screening for early detection. Saliva testing can thus help in early effective diagnosis, better prognosis, and for monitoring post-operative status. Thus, including salivary biomarkers in oral cancer diagnosis can improve the survival rate in the oral cancer patients. Thank you. These were the references I used.